Welcome back to the deep dive. Today we are tackling Gray's Anatomy, chapter 36, the face and scalp.
hmm
This is notoriously one of the densest and most interconnected regions in the entire body. It's challenging terrain, for sure, especially when you don't have diagrams in front of you.
And that's exactly the mission today. We're going to take those two-dimensional maps you see in the textbook and, well, build a detailed three-dimensional structure right here in your head.
Okay.
We really need to focus on the layers, the skeletal architecture, those dynamic muscles of expression, and, of course, the crucial neurovascular pathways running just beneath the surface.
The moment you start tracing the facial nerve or looking at the architecture of the orbit, you just realize how many critical systems converge in such a small space.
Absolutely. This whole region is structurally complex, it's highly vascular, and it's critical for almost every specialty, from trauma surgery all the way to aesthetic procedures.
Right.
Understanding the precise relationship between a vessel, a nerve, and a muscle, often within millimeters, is just paramount. So let's start the descent.
Okay, let's unpack this, starting right at the top of the scalp. The scalp is famous for two things. It's mnemonic, and, well, it's a tendency for some pretty dramatic bleeding. So for the listener, walk us through the 5 layers that give us that Scalp acronym.
The mnemonic is your perfect guide from superficial to deep. So S is for the skin. It's thick, it's hairy, and it's rich in sweat and sebaceous glands.
And what makes it bleed so much when it's cut?
So that brings us right to C, the dense connective tissue layer.
Okay.
This layer has the body's richest cutaneous blood supply, but, and this is the key, because that connective tissue is so dense and rigid, it actually holds the cut vessel walls open. It prevents them from contracting.
Wow, so they just stay open
They
now.
stay open, leading to that profuse, sustained bleeding that often looks much, much worse than the injury actually is.
That's fascinating. The structure itself is a hindrance to hemostasis. So what's next?
A is the aponeurosis, or the galea aponeurotica. This is a tough, fibrous sheet that acts almost like a helmet. It connects the occipital belly, the occipitalis, and the frontal belly, the frontalis of the occipitofrontalis muscle.
And the final 2 layers are critical for trauma and infection.
Yes. L is the loose areolar tissue. This is your danger space.
The danger space.
Exactly.
Yeah.
Crucially, the top 3 layers, S, C, A, they all slide easily over this loose tissue. It's the plane where blunt trauma can cause a massive scalp avulsion,
Just shears it right off.
shearing the top layers right off the skull. And because it's a loose space, infections or fluid can spread incredibly fast.
Last one.
Finally, P is the pericranium, which is simply the periosteum covering the bones of the skull.
Okay, that sets up the scalp perfectly. Moving down to the face, let's talk about the surgical roadmap. The source material really emphasizes the relaxed skin tension lines, or RSTL. Why is a surgeon's ability to follow these lines so important?
The principle is purely about minimizing conspicuous scarring. It's a cosmetic and functional thing. RSTL follow the natural orientation of collagen fibers, so they correspond to the fine natural furrows that form when your skin is relaxed.
So you cut with the grain, not against it.
Precisely. When a surgeon places an elective incision parallel to these lines, the resulting scar is much less prone to stretching. If you cut across them, that scar will always be more visible.
So RSTL helps keep things clean on the surface. But when surgeons go deep for a lift or reconstruction, they need a map for the structural foundation.
And that brings us straight to the SMAS,
The unbelievably important SMAS.
the Superficial Musculo-Aponeurotic System.
Yeah.
It's described as a critical single-tissue plane, and it's highly variable. In some areas, it is muscle, but in others, it's a tough fibrous sheet.
And it connects down into the neck, right?
Critically, yes. It's continuous inferiorly with the platysma muscle in the neck.
So when a surgeon talks about a deep plane dissection, they are often meticulously working deep to that SMAS layer, keeping that plane intact.
Exactly. And you see the same utility of distinct fascial layers up in the temporal region. Up there, you have the temporoparietal fascia, which is superficial, separated from the temporal fascia, which is deep. And what's fascinating is that the temporal branch of the facial nerve runs right between those 2 layers.
It's protected, like a wire in a conduit.
Perfectly put. Identifying that space offers a surgical safeguard plane to protect that very vulnerable nerve.
Let's move deeper then to the bony scaffolding. The skull is an engineering marvel, but it definitely has its weak spots.
It does.
Let's start with the parietal bones, the roof and sides. When you're visualizing the cranium, what are the 2 crucial superior angles that define the major sutures?
We can use those angles like cardinal directions on a map. So anteriorly, where the frontal and sagittal sutures meet, you have the bregma.
Bregma.
That's the anterosuperior angle. Then if you move posteriorly, where the sagittal and lambdoid sutures meet, that's the lambda.
Okay. And what about the weak points below? Which angle should raise the most alarm, clinically speaking?
Oh, that would be the sphenoidal angle, the anteroinferior one, which marks the Peytirian region.
The glass jaw of the skull.
That's what they call it. Its internal surface is marked by these deep grooves for the middle meningeal vessels. A hard blow to this very thin area can fracture the bone, tear the underlying artery.
And cause an epidural hematoma.
A rapidly expanding one, yes.
Moving to the frontal bone, the bony forehead, the prominence of which structures is directly related to the development of our frontal sinuses.
That would be the superciliary arches. They are the curved prominences right above the orbits, and they meet centrally at that smooth elevation known as the glabella.
Okay.
And these structures, they just become more prominent as the frontal sinuses grow and pneumatize. Inferiorly, the supraorbital margin is key. It often contains a notch or even a complete foramen.
Which is where the supraorbital nerve comes out.
The supraorbital nerve and vessels, exactly. It defines a very predictable neurovascular exit point.
All right, now for the central midface. It's structurally intricate, but, terrifyingly fragile. Tell us about the complexity of the ethmoid bone.
The ethmoid is. It's like the architectural lace of the midface. It's cuboidal, extremely thin-walled, and just structurally critical.
So how should we visualize it?
You have to picture its three key components. First, the cribriform plate. It forms the roof of the nasal cavity and allows the olfactory nerves to pass down.
Okay.
Then you have the perpendicular plate, which forms the upper part of the nasal septum, and then there are the lateral walls where you find the orbital plate, or lamina papyracea.
Paper thin.
Exactly. Lamina papyracea literally means paper layer. It forms a huge part of the medial wall of the orbit, and its fragility is precisely why it's so often the site of fracture and orbital trauma.
And to complete that midface framework.
You have the maxilla, which contains the large maxillary sinus, and on its anterior surface is the infraorbital foramen for that nerve and its vessels. Then the zygomatic bone forms the cheek prominence. It provides that crucial structural buttress for the whole midface.
Let's move to the dynamic element, the muscles of expression. Just a reminder for everyone, they're all innervated by the facial nerve, CN7. How do we best categorize them functionally?
Well, we can group them by region. So you have the epicranial group, which is occipitofrontalis, the circumorbital group around the eye, like orbicularis oculi, and then the really expansive buccolabial group for the cheeks and lips.
Let's focus on that orbital sphincter, orbicularis oculi. It's not just one muscle. It has three parts, right? And they each have a different job.
It does. The orbital part is the voluntary sphincter. That's for forceful tight-eye closure. Then the palpebral part is internal, and that's responsible for gentle, involuntary closure. Blinking.
And the third one?
The lesser-known lateral part, which helps drain tears by pulling the eyelids medially. The distinction between the orbital and palpebral parts is so critical when you're assessing nerve function after an injury.
Moving to the mouth, the movement of the lips is integrated by a convergence point called the modiolus. Why is this knot of tissue so functionally important?
The modiolus is, you could say, the conductor of the oral symphony. It's a dense, compact, mobile, fibromuscular mass just lateral to the angle of the mouth. The text notes that at least 9 different muscles insert or interlace here. It's the dynamic pivot point. It integrates smiling, speaking, chewing, everything.
So if you damage the modiolus,
you fundamentally alter communication and feeding.
That really puts its importance into context.
Yeah.
And the main cheek muscle.
That's the thin quadrilateral buccinator. Its main job is to compress the cheek against the teeth during chewing to keep the food bolus from, falling into the side of your mouth.
And this is the one the parotid duct pierces.
It's a key landmark. Stenson's duct runs horizontally across the masseter, then turns sharply inward to pierce the buccinator right before it opens opposite the second maxillary molar.
And the primary lip sphincter, orbicularis oris, it's not just a simple ring, is it?
Far from it. It's incredibly complex. It's described as 4 quadrants, a larger pars peripheralis and a smaller pars marginalis.
And the distinction between those two parts?
The pars marginalis is highly evolved in humans and is specifically associated with refined speech. Its vertical pull changes the profile of the vermilion border, creating these precise labial chords you need for consonantal sounds like P, B, or M.
Incredible. Okay, let's trace the major vascular and nervous highways. The face gets its rich blood flow primarily from external carotid branches. The key artery here has a fascinating path.
That would be the facial artery. It comes up from the neck and enters the face just anterior to the masseter muscle.
Where you can feel its pulse.
Exactly. You can feel its pulse right as it crosses the mandible's lower border. But what's really remarkable is its tortuous course. It doesn't run straight. It meanders up along the nose, terminating as the angular artery near the eye.
It's like a moving garden hose.
That's a great way to put it. That tortuosity is essential. It allows the face to move, to stretch and smile and chew without cutting off the blood flow.
And what feeds the lateral scalp?
That's the superficial temporal artery, the smaller terminal branch of the external carotid.
Yeah.
You can feel its pulse over the zygomatic process. It divides into frontal and parietal branches that supply the lateral scalp.
Now, for sensation, which is dominated by the great trigeminal nerve, CNV, we need to visualize that sensory map of the face.
We divide the face into 3 distinct sensory fields. So V1 ophthalmic covers the forehead, upper eyelid, and the dorsum of the nose, to nerves like the supraorbital.
Okay.
Then V2 maxillary covers the cheek prominence and upper lip via the infraorbital nerve, which comes out of that foramen we identified earlier.
And V3?
And finally, V3 mandibular covers the mandible, lower lip, and part of the temple, using nerves like the mental and auriculotemporal.
Switching to motor control. The critical path of the facial nerve, CN7. This is where damage can cause just devastating functional loss.
The facial nerve exits the skull at the stylomastoid foramen, gives off its branch to occipitalis, and then dives directly into the substance of the large parotid gland. Inside the gland, it branches out extensively, forming the pes censorinus, which means the goose's foot plexus.
And the 5 terminal branches emerge from there. Can we give the listener a standard mnemonic?
Of course. The classic sequence, remembering the TCBMC pattern, is temporal, zygomatic, buccal, marginal mandibular, and cervical.
And you have to highlight the marginal mandibular branch.
We absolutely must. It runs forward onto the platysma muscle toward the angle of the mandible, supplying the lower lip muscles. Its course, right near or just below the mandible's lower border, makes it so vulnerable during surgery or trauma in that region.
Okay, this chapter dedicates a lot of time to clinical correlation, particularly trauma. For mid-face fractures, there's the Lefort classification. How do we differentiate these 3 levels?
Lefort classified these based on the level of horizontal separation from the cranial base. So Lefort is the lowest. It's a horizontal fracture separating the alveolar process and the hard palate for the rest of the maxilla.
So the whole upper dental arch is mobile.
Exactly. The whole thing moves.
And level 2 is the pyramid.
Lefort thinks is the pyramidal fracture. It involves the nasal bridge, runs through the medial orbit walls and the infraorbital rim, and then back through the pterygoid plates.
Because it's a triangle.
A big triangular segment of the midface is separated from the zygomas in the skull base.
And the most severe, Lefort third.
That is Lefort III, or craniofacial disjunction. Here, the fracture passes through the nasal base, across the fragile ethmoid, and involves the zygomatico-frontal sutures. The entire midfacial skeleton is separated, or disjuncted, from the cranium.
Another really common trauma is the orbital blowout fracture. Why is the lamina papyracea and the orbital floor so often the weak link in eye trauma?
It's pure physics. The force of a direct, blunt trauma like from a fist or a ball transmits pressure inward. The orbital contents are displaced, and that pressure has to go somewhere.
And it goes through the thinnest walls.
It forces a fracture through the 2 thinnest walls, the orbital floor or that medial wall, the lamina papyracea we talked about.
And when that happens?
When that happens, orbital fat, or even the inferior rectus muscle, can get trapped. And that leads directly to restricted eye movement and double vision, or diplopia.
To wrap up, let's revisit the parotid gland. It really acts as a geographical hub for the face. Can you give us the deep to superficial order of the 3 key structures that pass through it?
Absolutely. Think of it as stacked pipes deep inside the gland. Deepest is the high-pressure system, the external carotid artery and its branches.
Okay.
Next up is the low-pressure system, the large retromandibular vein. And finally, most superficially, is all that multi-strand electrical wiring. The facial nerve, CN7, and its plexus.
And just to reiterate Stenson's duct path one last time.
The parotid duct runs across the tough masseter muscle, takes a sharp turn inward, and crucially, pierces the buccinator muscle before entering the oral cavity.
And that leads us to the classic clinical consequence of trauma here, Frey syndrome.
Frey syndrome, or gustatory sweating. It's a fantastic example of neurological crossed wires.
Right.
After trauma, the parasympathetic secretomotor axons that were supposed to reinnervate the parotid gland mistakenly grow back and connect to the nearby facial sweat glands instead.
So what happens?
The result is that when the patient smells or tastes food, instead of salivating, they start sweating. They experience prominent sweating, warmth, and redness on the skin right over that parotid region.
What a detailed trip. We covered the scallop layers, the surgical roadmap of RSTL and SMAS, the fragile architecture of the midface, the dynamic interplay of the modiolus, and the critical path of the facial nerve.
Yeah, and the key takeaway is just how highly integrated structure and function are. Every single anatomical decision, from the tortuosity of the facial artery allowing movement to the convergence of muscles at the modiolus for speech,
To the weakness of the Pterian.
to the weakness of the Pterian. It's all tied directly to function or vulnerability. And that's why this deep dive is so vital.
Well, thank you for navigating this incredibly complex territory with us. We really hope this deep dive helps you build a strong, detailed mental picture of the face and scalp.
Visualize those planes, trace the nerves in your mind, and you will have mastered this chapter.
We'll catch you on the next deep dive.